to our esteemed panelists. We have three marvelous speakers here with us today. We have Dr. Coady from the Substance Abuse and Mental Health Services Administration. We have Dr. Elise Simonson from the National Governors Association, and Major Lambert, who's the immediate past president of the American Jail Association and retired as from the Sheriff's Office in Prince William County here in Virginia. So we got lots of different perspectives on this particular topic. So I am delighted to have them here. I direct you to their full bios on our website. And I'd like to begin with Dr. Coady. Can you tell us what's happening from your perspective at the federal level?
No, first of all, thank you for the opportunity. Really looking forward to the conversation. And if it's okay, I'll look forward to pulling up my slideshow, which we can kind of get into what's happening within SAMHSA. So I have 15 minutes. I definitely want to be thoughtful to my other presenters. So I have 18 slides. I'm going to go very quickly, but hopefully it sets the stage and we can have some good conversation. So within the Substance Abuse and Mental Health Services, SAMHSA, our mission is to reduce the impact of substance use and mental illness on America's communities. I'm the acting director for the Center of Substance Abuse Prevention, CSAP. Within SAMHSA, we have also 4 other centers, one that focuses on statistics and quality, mental health, as well as substance abuse treatment. Our assistant secretary is Dr. Delphine Rittman, who I'm very happy in terms of her leadership, in terms of really helping us to look at our policies and how they can reduce the harms both to individuals and communities related to substance use disorder. So in terms of our near-term priorities of what we're looking for at the agency, we have 5 near-term priorities. We're looking at preventing overdose death. And we know that overdoses are caused by a variety of substances, mostly contaminated through fentanyl in our communities now. We also access to crisis services, including suicide prevention. And we know that substance use disorder, there is definitely co-occurring factors with suicide and substance use disorder. We're also looking in terms of preventing. One of the best policies we can do is prevention, and that's really what we focus on in terms of youth and young adults, in terms of preventing addictions from occurring in the first place. Also looking at integrating our service delivery system in terms of primary care and behavioral health care, so that we have no wrong door in terms of accessing early behavioral health treatment. And also looking at our data, how we can use our data to really make informed policy decisions and programmatic decisions. And then we have 4 cross-cutting issues, looking at equity, workforce, financing, and recovery, which really is something that really spreads across all of our different priorities. So in terms of looking at the landscape, folks are very cognizant of the fact that, over the overdose epidemic, it's the opioid epidemic has occurred for some time frame now. And in particular with COVID, we definitely had a spike and an increase in terms of overdose deaths. We also know in terms of the mental health stress on youth, in terms of families over the past couple of years with COVID, we've seen increases in suicide. So the stressors in terms of what are exhibiting themselves in our society are significant. And we know that mental health in particular is a risk factor for substance use disorder. So in terms of being to look at our policies, in terms of how we're able to engage people early and easily, that's something that we're really trying to do as a center. So in terms of looking at this sort of the bigger picture in terms of what drives some of our policies, we look for the Office of National Drug Control Policy within the White House. They just released a whole government approach to addressing substance use disorder and the overdose epidemic. Prevention is an area that's highlighted in there in terms of significant interest to our center, as well as harm reduction, treatment, and recovery, as well as law enforcement initiatives. So really looking at the different levers that we have across the federal government, this is really, I would say, a framework that the White House sort of puts out for the next 4 years to help guides their existing policies, and then in terms of how our agencies implement those policies. So speaking for substance use prevention, most of our work is done through coalitions and communities. And a coalition will be a combination of many sectors within a community. Youth servicing agencies, treatment providers, schools, businesses, law enforcement, after-school programs, faith-based community, and it goes on. What really takes a really community-based approach where we want to make sure our messaging and our programs, evidence-based programs related to substance abuse, are really in a way that individuals can access them. So that's why we talk about the 4 E's of a substance use prevention system. Early action. And oftentimes, we know that many substance use disorders begin in youth in terms of 50% for the age of 15, 75 for the age of 24 years old. However, it can also mean early in someone's life when there is a significant risk factor, divorce, loss of job, loss of house. There's these timeframes, no matter what age it is, we want to intervene early. We also want to make sure that we have easy access to prevention services. So whether you live on one side of town or another, or go to one school district or another, you should be able to have those easy access to prevention system services. It could be parenting classes. It could be social emotional learning. We also want to make sure our delivery programs work for the community. It speaks to the community. It's a good fit, as we would say, both in terms of the evidence-based, the financing, and as well as responding to the culture of that community. What might work in a community where I live might not work in a community where you live. So we really want it to be culturally responsive to communities. And lastly, equitable. We really want to make sure that everybody has an opportunity to develop opportunities for good health. And that means, no matter what zip code you live in, that shouldn't be the determining factor for your health. That we should look at the policies that really impact all of our zip codes and making sure that folks have access to good health. So within the prevention field, we often say prevention is the front door to our system. That whether it's activities in schools, whether it's activities in community awareness, whether it's activities in terms of harm reduction, in terms of other based naloxone distribution, prevention really is a linkage to whatever service that an individual needs to be well. So we really try to meet individuals where they are with our prevention services through the work of our coalition. It can be where you live, work, play. We want to make sure that we have the mechanisms and the system set up so that we can get out, number one, factual information about substance use. And then number two, really intervene early if we see significant increases in risk factors for an individual's life, so their family's life. And then number three, refer them to whatever support they might need. It might be housing. It might be treatment. Whatever it is that they need that we can reduce the risk of substance use, we want to be able to provide those referral networks. So we have the substance use prevention is kind of categorized by the Institute of Medicine model, where we look at health promotion, substance use prevention, treatment, and then recovery. It says maintenance in here. And depending upon the individual's risks, we look at universal, which would apply to globally to a particular population, selective, which would be a group that might have a particular set of risks, might be a particular age group, and then indicated individuals who have really showing early signs, not yet clinical, they need treatment, but perhaps on that trajectory. We want to work across that entire system to make sure whatever prevention service you need, that we give you the right dose of prevention at that particular time and raise the intensity level depending upon those risks that you have. The more risks that you have, the more we want to provide more support, more resources so we can be more preventative. We've heard of adverse childhood experiences. We want to create as many positive childhood experiences as we can within this frame. And we also look to our relationships I talked about with other systems that we want to link to, whether it's mental health promotion in terms of looking at mental health first aid in a community or suicide prevention in a community. We're also looking at harm reduction. When I talk about harm reduction, I talk oftentimes in terms of meeting people where they are. And if they are an individual who might be using substances, how is it we can provide naloxone, fentanyl test strips, or syringe service programs, which can reduce the impact of substance use and contribute to a person's health. We also want to look at how we can access recovery. Recovery can begin everywhere. So how is it that prevention and recovery can work in a community to have a healthy environment? We have shared space in which recovery community centers, as well as prevention coalitions, are working on the health of that community. And also in terms of treatment, how do we close the gap between, like I mentioned, in terms of it's a long distance from prevention to treatment. We want to be able to cover that gap to make sure people have the resources that they need. Another area in terms of policy, we're looking at the social determinants of health. I had mentioned before in terms of your zip code, in terms of your access to education, to healthcare, the neighborhood that you live in, the environment, as well as the social and community context, economic and housing stability. All of those have a significant impact on your health. In particular, they're often risk for substance use disorder. So how is it that we can look at our policy in terms of what's working programmatically well within communities to address the social determinants of health? What should be changed within the community? This is very upstream approaches toward looking at the health generally, but there's a lot of shared risk factors with social determinants of health as well as substance use disorder. So to do well by our communities, it's important that we continually check to see if our policies are addressing the social determinants of health, a very upstream approach. Now let's look at some other factors that are influencing substance use policies. Sometimes we make assumptions in terms of the way things should be or what works or people. And it's a combination of factors in terms of what works for that community. That's why part of our planning process is to engage multiple stakeholders within a community in a coalition. We want all members of the community to be present because that's really going to give us an accurate description in terms of what the needs are, where we can provide our prevention services. And also the community needs to drive in terms of what they value and make sure that we align our evidence-based programming with the community values. And through that, we can establish policy that is really important toward addressing the health of that community. And some examples, we look at what policy we have to address stigma, what policy to address alcohol usage within the community, or cannabis, or prescription opioids, or psychedelics. These are all areas where there's specific policies that might apply. And we know that, for cannabis, that might vary per state and per county. Alcohol, there might be certain counties in terms of the proximity to certain settings in terms of which alcohol density plays a factor. Stigma, we look at the Mental Health Parity and Addiction Equity Act. There's a lot of policies that we can have in terms of that, whether it's accessing treatment, whether it's looking at our environment or the availability of substance uses and what that means. Because many things like psychedelics that have a great promise, we want to make sure at the same time that we balance in terms of risk versus the benefit of a particular substance. And that's why our policies, being thoughtful about them, can be very sensitive. So we make great success over time in terms of some of our policies. I think one of the best ways to show that is through alcohol use for 12 to 20 years old. We've seen really over the past 20 years, we've seen the impact of those policies in terms of looking at the decline in terms of substance use, alcohol, in terms of underage youth. One of the major efforts that drives us is an interagency coordinating committee within the federal government that brings together all these sectors, from health to transportation to justice, all people working together to look at how we can reduce alcohol use. We've seen policies that have reduced the drinking age over time, and the impact that has had, raised the drinking age, I'm sorry, not increased. Going to see what direction the arrow goes. But we see that the impact that has had in particular communities in terms of whether it was, 18 to 19, now 21, in terms of, we also see that with tobacco as well. So there's things that states can do. And we look in terms of what's the use in terms of policy with our tax funding. That is an area that we've seen some in terms of programs being taxed, as well as the tax on alcohol or tobacco, and have seen the change in behavior related to that. I talked about outlet density. We also talked about the hours of a day that a business or a place might operate. There's many different things that our coalitions can do at the community level to create that particular environment. And then I mentioned harm reduction real quickly. Previously. Well, harm reduction is a term that's thrown around a lot, and I think often misunderstood. There's three areas within harm reduction that the National Drug Control Policy strategy supports: syringe service programs, fentanyl test strips, as well as naloxone distribution. And sometimes you'll hear, well, why would we do that in terms of an individual who has substance use? Why would we, want them to test their drugs? Why would we want to give them naloxone? Why would there be access to clean syringes? Because harm reduction is an opportunity to engage people where they are, and they might be ready for treatment, ready for recovery. They might not be, but the fact that an individual still needs dignity, we could still decrease other co-occurring illnesses in terms of prevent HIV, and prevent hepatitis C. The fact that we can engage someone, and individuals who access harm reduction services are often 5 to 6 more times likely to get into treatment and recovery. So it's often an engagement strategy. And in terms of, number one, it keeps individuals healthy. And number two, it really is a place in our community that, sometimes there's syringes perhaps that might be in other places where they don't place to dispose of them. So it helps keep our community safer in terms of preventing infectious disease. So harm reduction is something that is really, it's the first time it's been reflected in the drug control policy strategy, as well as reflected throughout SAMHSA programs and other programs, public health strategies to reduce the impact of substance use will also prevent overdose deaths. So something just kind of think about in terms of asking the participants is, understand the issues in your community. Bring the different sectors together. Conduct a policy research and investigation. We know that there's things that works in different communities that might be similar to yours. Look at what those aspects are, some of those best practices. Build the relationships and educate the decision makers. We know that policy is often something you might have to do with elected officials or other individuals beyond the program. So build that consensus, mobilize the support, and make your voice heard. That's how we often see our coalitions impacting and affecting community change. So with that, it's my last slide. I'm happy for the opportunity to be part of the discussion later, and certainly we'll hand it back to you, Doctor.
Thank you so much, Dr. Coady. And I'm going to turn it now to Dr. Simonson. We've just heard a really nice overview of some of the federal policy space, and in particular around prevention. Dr. Simonson, can you help us understand what are the states doing at this point from the perspective of your Center on Best Practices through the NGA?
Absolutely. Yes. Thank you so much for having me here. Thanks for the invite and the opportunity to contribute to this important discussion. My name is Elise Simonson. I'm a senior policy analyst in the Public Safety and Legal Counsel program at the National Governors Association. And I've served on our drug policy team for the last 4 years. Before I get started, though, I did want to note that I am speaking in my own individual capacity and not on behalf of the governors. So next slide, please. So this presentation will be a broad scan of what states have done and provide high-level takeaways and information. I'm going to quickly run through who NGA is, our last decade of work on this issue, and then I'll be highlighting some state innovations throughout the drug overdose epidemic before moving on to what we're currently seeing for state initiatives within the harm reduction space. And finally, I'll just briefly highlight a few lessons learned.
We'd love that. And our audience is quite familiar with NGA, so you feel free to just zip through that part briefly. Thank you.
Great. Sounds good. All right, so next slide. All right, so good to know that you're all familiar with NGA. I'll just say that our drug policy team then has been a partnership between Public Safety and Legal Counsel program as well as the health programs at NGA since its inception in 2012. So next slide, I'll talk a bit about our work since that time. All right, I know that the wonderful folks are going to be dropping in a few resources. So I'll be referring to a couple of things in these links, but just want to make sure folks have them. But really, the work that you see here is really been started at the behest of the governors. So over the last decade, we've worked with almost every state and territory as CDC's technical assistance provider to states. And as the opioid crisis worsened, governors convened around this at our annual summer and winter meetings. And one of the links is the 46 governors signed a compact to fight this in, I think, February 2016. And NGA is really, as you may all know, an on-call resource for whenever a state has a research question or needs. So we have been working in this space on short and long-term technical assistance. And the slide lists some of the projects in our drug policy shop. And so these range from day-and-a-half roundtables to year-long intensive cohort work with states. We're currently working intensively with 4 states on stimulants and polysubstance use. And we've just finished work with 16 states on expanding MOUD in state correctional facilities. So I'll be highlighting some of these states shortly. But those links have our various publications as well as information on our national network of state drug experts, policy experts called OSAN, or Opioid State Action Network. And we hold these calls monthly to hear about state trends, in which we hear about state trends. So next slide. So getting into the meat of the presentation then, states have really tried to move the needle in the drug overdose epidemic through multiple levers. States have, this slide includes many of the early innovations of the opioid epidemic, but states really continue to leverage these strategies. First to highlight is really that governors can declare public health emergencies. Of course, this is now understood as a broader power of governors through COVID, but governors have used this power as it relates to drugs and death of their citizens in the past. So we saw about 8 states use this power in the mid to late 2010s for opioids. And nationally, we've seen presidents use this power too for drugs. So President Trump declared the opioid crisis, a public health emergency in 2017. Some other innovations that are on this slide, they include increasing access to treatment via peer sources such as peer recovery coaches, connecting community treatment providers and community corrections, broadening naloxone access, including engaging schools. So that's, opioids in health education or ensuring that school nurses have access to naloxone. There's other innovations listed here, and I'm happy to get into those during Q&A. So next slide. All right, so for this conversation, and I believe what the main question was, what are some of the state initiatives in harm reduction currently? We are currently working with states on some of these topics listed on this slide. So first, drug checking. This form of harm reduction is really critical for people who use drugs, as the drug supply continues to be adulterated with fentanyl. And as this audience probably knows, with SOAR 2.0, states could use federal dollars to distribute fentanyl test strips. So from my interactions with state public health departments, this was an overwhelmingly positive change. And as I mentioned before, really, we like to see innovation when states best succeed when we see those partnerships between public health and public safety. So with this funding change, it's really important to acknowledge the role of law enforcement in this. So prior to this funding shift, a majority of states had drug paraphernalia laws that made possession of drug checking equipment or tools illegal. And this is still the case, but there have been a handful of states that have made adaptations since SOAR 2.0 funding. So states have taken various approaches to allow for either distribution or possession of fentanyl test strips. So these approaches include decriminalizing possession, removing language from current code, or what we would call carving out, or explicitly adding language to current code to include allowable use for testing of illicit substances, what we call carving in. So, for example, Arizona took a carving out approach where they removed specific words from their existing statute to permit the use of products like fentanyl test strips. On the other hand, some states like North Carolina allow fentanyl test strips by adding language that explicitly waives fentanyl test strips from the definition of drug paraphernalia. In our current policy academy, we've worked with Connecticut as they move forward to allow fentanyl test strips. So Governor Carney most recently signed this into legislation. Moving on to other initiatives, overdose reversal. Overdose reversal is an intervention that can save lives. As CDC noted in 2020, of the 92,000 deaths that year, 75% involved an opioid. So naloxone is truly it's a life-saving tool that needs to be readily available and funded and distributed by the state. And training, of course, is important here. And this goes for emergency services, to educators, to the general public. In 2021, Governor Holcomb of Indiana announced a statewide initiative for naloxone distribution. The governor announced funding to ensure that all 92 counties would have a naloxone vending machine that each would hold 300 doses. So they have even placed these in county jails to reduce the likelihood of a fatal overdose upon release. So that's one state highlight there. For SSPs, or syringe service programs, states can leverage federal funding streams to establish SSPs for personnel, for testing kits for viral hep or HIV, syringe disposal, education materials, These, of course, often include distributing naloxone and fentanyl test strips, which I just covered. Ideally, SSPs would see a one-to-one exchange rate for needles when it comes to people who use drugs coming in for a clean needle. States have made great progress here. One to highlight from a governance perspective was that in 2015, Kentucky legislation allowed for the State Department of Public Health to establish guidelines for local health departments when implementing SSPs. So that really gives the power to localities to then approve, but they ended up having them in many more places than they would have anticipated, I think, 7 years ago. So we've seen great progress there as well. I put supervised consumption sites here. I don't have a statewide example offhand, but I did want to include it as something we see as an upcoming and anticipated shift for statewide models. So given the SAMHSA harm reduction grant funding that was due a few months ago, we certainly anticipate this change, although my co-panelists that spoke before me may have more information on that, as I think the award announcements were made recently. Next, so MOUD, OTPs, OBOTs, these are all important components of treatment for opioid use disorder. States have taken various innovative approaches to implementation, and NGA has worked extensively in this space. As I mentioned, we worked with 16 states here. We hosted regional meetings in 2019 and 2020. So each of those states we worked with for 6 months. And there was a great deal of progress in implementing MOUD in state correctional facilities, as well as community partnerships for reentry, warm handoff, continuity of care. One of the key themes I wanted to highlight from that work is that we heard from states that there are many ways that state and local jurisdictions can collaborate and working together to expand opioid treatment, not just in state facilities, but also in jails, and ensuring the continuity of care for individuals upon release into the community was really important for states. During our project, California developed the robust integrated substance use treatment, I think ISUDT, inside correctional facilities. This treatment includes screening and assessment, MOUD, cognitive behavioral interventions, supportive housing, and trauma-informed care. During that broader work, the states raised the continuity of care upon release from incarceration, as well as access to treatment within the community as a challenge. So increasing reentry planning and coordination, leveraging resources to expand capacity, and utilizing innovative strategies such as telehealth can help improve outcomes for justice involved, those that are justice involved with an SUD in the community. Interestingly, that California treatment plan has an enhanced pre-release period that starts 210 days prior to release. I think that's one of the longest pre-release plans I've seen. And then one of the final notes here for state harm reduction initiatives is really just wanting to make a point on the importance of community partnerships. So not all communities are going to be on the same page regarding people who use drugs or individuals being released from incarceration, especially for those who fall into both of those categories. So bridging the gap between corrections and behavioral health and learning to speak the same language regarding SUD treatment and supervision of individuals in the community can help successful programs and improve outcomes. So working with local health departments to ensure services are certainly a life-saving strategy from my point of view. All right, and for my final slide, moving to lessons learned from the broader overdose epidemic, I'll leave you with a few of these lessons learned. Public health paradigm is key. So this is a public health crisis that requires public health focused solutions, but law enforcement really plays a critical role, and it's key in early recognition of the scope of the epidemic and what's working and what's not working. As I said before, this partnership between public safety and public health really is critical in the states, and that's when we observe the most success is when they're working together. With that, the governor's leadership is also critical. They really provide a mandate for action, set the tone for the state, and convene the key decision makers in the state. Buy-in from governors and their use of their convening authority to direct agency heads to work together can assist in building bridges where those silos may exist. And then treatment is essential, especially when targeting criminal justice involved population and making those connections while still incarcerated. And of course, data and evaluation must drive policy and practice, and states need to always be thinking about what's next and what they've learned to date so far. With that, I'm happy to take questions when that time comes, but thank you all for your time.
Terrific. Thank you so much. And Major Lambert, let's turn it to you, please. Could you tell us, coming out of your serving as president of the American Jail Association and your heavy involvement in the sheriff's office in Prince William County, what innovative things are happening in the legal carceral system? And you can give an overview of, we know there are different partners within that system. What's new with respect to substance use treatment and prevention?
Thank you very much. And thank you for allowing me to be here. It's an honor to kind of talk about what's going on in jails. Dr. Simonson talked about prisons and jails. Jails are incredibly different. California, she mentioned, had 210 days that they would start with some reentry work. Oftentimes, jails don't hold people 210 days. They're very fast moving. It's very cyclic in a jail. There are about 3,300 jails in the United States. And out of those 3,300 jails, they are consisting of small, medium, and large. Small would be a 2-bed facility way up north in Minnesota, compared to LA County, 16,000, 20,000 at any given time. And resources are always a challenge. But what is happening in jails across the country is the movement to educate staff about what this is. So law enforcement and public health have collided, and they've collided in an excellent way. The education was the first step in helping jail staff, correctional folks, understand why this is happening. In the corrections world, as a public safety piece, our role is to ensure safety and security in our nation's jails. Safety was one of the biggest pushes and drives in terms of fentanyl introduction into our nation's jails. It was a staff safety risk, and it was a risk to anybody that would visit a jail just based on property that they bring in with them or mail that is coming in through our facilities. There has been technology that has been introduced in jails across the country to prevent the fentanyl introduction into our jails across the country. In addition to that, medication-assisted treatment is at the forefront of everything that we do. So educating staff, the next step was identifying those justice-involved individuals as having a substance use disorder. The biggest substance use disorder that exists in jails across the country is opioids. That is the #1 challenge for jails across the country, is contending with those folks that are placed in our custody and care that are addicted to opioids. So identification, and then one of the bigger challenges is getting them to concede that they have a problem and allowing us to help them. Oftentimes when you are dealing with criminally justice-involved folks, it is not uncommon for attorneys or defense counsel or whomever to say, don't talk to them, don't admit to it, you'll have to stay in jail longer. When in fact, that becomes a public health related issue within the confines of a correctional environment. When you're in a congregate setting, when when you're in a congregate setting, it is incredibly difficult for jail staff and our medical staff to help treat those that are in our care when they're worried about it affecting their criminal component. So we've worked very diligently across the United States in developing relationships and collaborating with our partners, whether it be judges, whether it be Commonwealth or defense attorneys, pretrial, local community services, whatever the case may be. We all needed to be at the table. We needed to educate ourselves and educate each other as to what we do. Jails are like a mini emergency room. We get very sick people, people that are addicted to any number of substances that you could possibly imagine. We provide medication-assisted treatment for those that perhaps already have a prescription. We induct those that don't. And this is not every jail that is doing it. Every jail doesn't have the resources that some of your larger metropolitan jails do. Unfortunately, what drives a lot of the decisions and a lot of policies within the jail communities is case law. And there's a number of case law that has driven a lot of the policies that are now being expected in our communities, is that medication-assisted treatment is no different than heart medication or blood pressure medication. And that took several years for staff to kind of adapt and wrap our arms around. But I am happy to report that jail folks, correctional folks, want nothing more than to not see the same people coming back with substance use related issues. We dedicate ourselves to helping. Unfortunately, jails, are in the spotlight for bad things that happen in our congregate settings. COVID was extremely difficult for jails across the country, and it was exacerbated with the uptick in mental health related issues, as well as the opioid crisis that we were contending with. So imagine jail correctional professional staff working in a congregate environment that was dealing with a pandemic, dealing with people that are so incredibly sick, addicted to substance uses, different types of substances, and not wanting to get help. So it has been a challenge. What is happening in terms of harm reduction goals, obviously, as Dr. Coady had mentioned, needle exchanges, safe places cannot be done in a correctional setting for the safety of. So our harm reduction goals is helping our justice involved folks understand that they have an addiction and it can be different. Wrapping our arms around them and trying to get them to agree to allow us to help them. That is some of the bigger challenges. One of the real big challenges that jails are confronted with is 42 CFR, which is a federal statute that is even stricter than HIPAA. Is sharing of information from let's say a local community services with jail staff. Mental health records you can share all day long. Substance use was created under 42 CFR to eliminate stigma, which Dr. Coady talked about earlier on. The unfortunate part is without sharing of information, and we'll talk about the signatures in a minute, the release, without sharing of information, it delays jail professionals, our doctors and our RNs that are outfitting our nation's jails. It delays them in getting them the treatment that they need early on. 42 CFR has been problematic for jails across the country. At the national level with the American Jail Association, we've been working with local legislators to identify other ways that we can share information. Oftentimes it is incredibly challenging when you're contending with somebody that is justice involved that is co-occurring. And it is unethical, absolutely unethical to ask them to sign a release of information. from our view. So when you have somebody that is suffering from substance use disorder and also has a mental health diagnosis, signing of a release of information is likely not going to happen. So there has been a tremendous amount of delay in continuity of care for those folks. Naloxone in jails is a thing. I didn't think that we would ever see that, but jails across the country have outfitted their staff with naloxone. A lot of jails, including Prince William, are issuing naloxone to inmates as they leave our custody. And the final thought is about the warm handoff, right? The reentry, the robust reentry. Again, I want to be clear that jails are very short term. It is not uncommon for somebody to be criminally charged and within 12 hours released. And the unfortunate part about that is just when we think we've got our arms wrapped around them to start connecting them with treatment, they get out. Subsequently, and unfortunately, and it's tragic, those are the ones that are creating the uptick in our overdose statistics. And it's sad. Our community needs to respond. And we've talked about this on multi-levels, that we can't keep them incarcerated. There's an order for them to be released back into our community, but the short stay in jails is quite challenging to get them connected to an appointment or to a local Suboxone dispensary or what have you. It is incredibly challenging. But I'm happy to report that your corrections professionals across the United States and the territories are working diligently to develop policies that protect our justice-involved folks. They are caring and compassionate set of people, and you would be most proud to know that they genuinely care about the people that we are tasked with taking care of. And our opiate epidemic has been at the forefront of most every conversation. It brings incredible challenges to jails. It is kind of the low level lying where you often don't know what's going on behind those walls, but we encourage you to know what is going on behind those walls. Again, jails confine the sickest of the sick, geriatric, substance involved, mental health, seriously mentally ill folks. It is quite the challenge. And I encourage every one of you on this webinar to know what goes on in your local jails. You are welcomed. We have to work together to achieve the results that we want to achieve, which is reduction in overdose, if not the absolute elimination of the overdose death rates, but jails can't do it alone. And we are ecstatic to have welcomed in our public health officials thanks to COVID. If anything good came out of COVID, it was the relationships that were developed with our public health folks, our local health department, our local colleges, universities. It has been a whirlwind, but we are excited to continue those relationships and hopefully working together, having webinars like this. It will eventually, we will see the numbers go down and lives being saved. So I thank you again.
Thank you for that overview, Major Lambert. I appreciate it. Sure. So Dr. Coady, we're going to turn this now to Q&A. And I want to start by, if you could give us an overview. You mentioned the Office of the National Drug Control Policy, and we also have the Centers for Disease Control, and we have Department of Justice. So where is the policy? Help us understand the policy space as it comes to substance use disorder at the federal level.
Sure. Well, the Office of the National Drug Control Policy is part of the executive branch, part of the White House. And, I obviously, I don't speak for them. I speak for my center. But, obviously the policy comes oftentimes from, the administration in terms of the larger sort of policies. Then there's obviously policies within then programs themselves in terms of, it might be the grant in terms of the scope of the grant, in terms of the activities, in terms of what legislature sort of provides. And then from there, then often then cascades down, I think, obviously then to community. But there's different types of policy that I think we can kind of look at in terms of, I think we had talked about what are the parameters in terms of like harm reduction, in terms of what the administration supports. So, that's something that obviously we would implement. And then, there's other elements that are a little bit more, I would say, in the weeds and minutia that SAMHSA would be making the decision on related to some of the policies. It's a little bit more on the program side.
And then in terms of the community coalitions, and we can turn this to Dr. Simonson, where do you see the more effective types of coalitions happening? Major Lambert mentioned involving the public safety community. So where do you see the more effective or more innovative coalitions occurring?
So from our perspective, we encourage governor's office or the agency staff that we work with when implementing these projects to work with their local health departments, local pretrial services too. There's a role here for diversion and deflection to be part of this conversation, so folks aren't ending up in the system too. So really knowing who your local community champions are, can help you get a little further there.
Terrific. And Major Lambert, what we're hearing a lot about opioid use disorder and fentanyl, and a degree of sort of opening up to the jail system as being part of the broader system of treatment, as people, if we think of perhaps incarceration as a marker of an acute condition, for example, or at least a transition point or an opportunity to intervene. Is that extending to other forms of substance use, do you think, or is it at the moment focused on opioid, fentanyl overdose, or do you see an opportunity for us to extend this to alcohol use disorder, for example?
Yeah, that's a great question. Alcohol use disorder has never disappeared from this setting. Alcohol use disorder is one of the scariest disorders that come through our doors. And, the training that your correctional folks receive is identification of those early onset behaviors or of substance use. But I would say, my career spanned 5 decades, and there used to be a distinction between a third of the United States where cocaine may have been on this side and, PCP may have been here and what have you. What we are seeing now is opioids. And what I fear from my lens is that other substances will take a back seat. Opioids are often responsible for overdose deaths within a congregate setting. The incarcerated individuals do not want to go through a withdrawal. It's a horrible thing to witness. But it is a horrible thing to go through. So, one of the things that we're doing at our level is ensuring that none of the other substances, especially alcohol, takes a back seat to what we are seeing with opioids. I think they all deserve the same amount of attention.
I wonder, Dr. Coady, fentanyl strips have also gotten a lot of attention as fentanyl has emerged as an important harm, or if you will. Has that opened up the dialogue to harm reduction more broadly? I mean, obviously we had Naloxone, Revive programs, but has this reopened the conversation on syringe safety, for example? Do you think, or are they still separate, somewhat siloed conversations?
I think harm reduction, organizations have been around for 4 decades, so I think and some of our federal partners in terms of have been in the syringe service program range for several for the past 20 years in terms of how it's really, I think, been framed in terms of looking at sort of HIV prevention, but then looking at it more broadly, I think in light of what we're hearing about in terms of really, I think the adoration of fentanyl and some of the challenges, I think that this has provided a broader combination. So what are all the tools and resources, recognizing how we can keep people safe, how we can keep people well, how we can prevent overdose death. So I think that conversation has broadened in terms of, as we start to see more science behind what are some of the effective ways that we can help people make educated decisions about their health. So I think, obviously it's none of these areas in alone as a standalone. I think it's important to recognize that, that's why we have multiple different partners in terms of talking to different perspectives, and fentanyl stress strips being one mechanism, but it's got to be a combination of all these particular levers in terms of us bringing them to bear to be effective, I think, in terms of mitigating the effects of substance use addictions.
Excellent. And Dr. Simonson, if you mentioned a little bit about the supervised consumption sites, and very gently mentioned that, and there are some challenges at the federal level with supervised consumption, but if you had a magic wand, what federal policies would you like to have a conversation about that you hear your governors are struggling with?
That's a good question. So I don't think my magic wand could get rid of stigma, unfortunately. And I think that's a part of the conversation here too. And that gets into the last question about fentanyl test strips and moving beyond, and is this broadening harm reduction? I think from our perspective, governors are really focused on, are still continuing to be focused on opioids, but also really focused on increase in other substances, particularly methamphetamine, which was classically more Western states were having this problem. We know that's not true anymore. And so we are hearing even our Northeastern states really focusing on this as well. So for me, I think, federal policy wise, it's really about the funding available to states so states can appropriately blend and braid funds to tackle a variety of issues, because when funding is narrowed into just opioids, states are really having trouble standing up other programming outside of tackling just opioids, while they're really, of course, struggling with stimulants broadly as well.
Thank you so much for that. And Major Lambert, what would your magic wand do if you could talk to your federal policymakers and make changes? What I heard CFR 42. What else would be on your to-do list?
Well, besides the restrictions that are set forward, especially with our criminal justice involved in terms of sharing of information for continuity of healthcare, regardless of whether it's health related or substance use related, I think the magic wand would be having a champion that is dedicated to every single state, that would bring all of the external stakeholders together to address it. Right now, there are so many different prongs, so many different tentacles that are trying to achieve the same thing, but it feels as though we are working really hard to achieve the same goals, but there are just too many of us. So I would really like to see it streamlined. I would like to see jails have a seat at the table at every juncture when we're talking about this. Look, if it is happening in the community, it is most definitely happening inside of a jail. Oftentimes it's the reverse. If we see it in the jail, it's gonna raise its ugly head inside of our community. And I think jails have a lot to offer. We have intel, we have information, and we have them, and I use this term loosely, but they're captive audiences. And this is the time that, as a harm reduction, ours are a little bit different. This is the time that we can educate, motivate, and get connected with the services that they so deserve and often are not available in the community in which these jails are in. So my magic wand would be bringing everybody together and more of a streamlined approach instead of pockets of individual organizations. We need to collaborate. And that's the only way that we're going to, I think, achieve the results that everybody wants to see achieved.
Excellent. And Dr. Coady, in the prevention space, what do you think? I can't help it. I'm an academic. What are some of the biggest evidence gaps? We're hearing Dr. Lambert say it might be an opportunity to have people recognize they have a substance use disorder, or they're on somewhere on the spectrum of perhaps moving towards a disorder. What evidence do we need to improve our prevention efforts, either at the local level or at the state level? What do you see as some gaps there?
I think what we hear from communities often is sometimes our research base isn't a good fit with the community. So how is it that we looked at some of the community-based practices and how the community-based practices, but great opportunity for communities and academia, I think, to partner in terms of, sort of that shared space to make sure it resonates with that community. And we take the community-based practices and provide the evaluation and make sure that, we do get the evidence base behind that. Oftentimes it's sometimes in the reverse direction where we'll embed something and say, hey, it's a good fit. I'm like, it doesn't necessarily fit. Let's go the other direction. So I think a combination of one, we could probably be more effective in terms of distributing and making sure that communities have access to the evidence-based options out there for those that exist. And then number two, helping to take what's working in communities and establishing evidence behind it. So that sort of continuum is something I think we can work with our partners, federal partners in NIDA, really, which we are doing to try to get to that space.
Absolutely. Excellent. And Dr. Simonson, what do you think are some of the evidence gaps? So you're listening to the dialogues among the state partners, and you've got a whole range of topics, or you've got working groups. Where are they finding the biggest holes where they want to do something and they're running up against, we don't know what the best thing might be?
Yeah, I'd say so. In the prevention space, I think we've seen issues in education. So, and that's across the spectrum. But how to approach education in youth and curriculum early on elementary. So, of course, they can't be tailored to certain substances, and they're kind of just broader. So, teaching strong foundations, social, emotional learning, all of that. So I think when we're talking to states, it's all often how early can we intervene, or when it's too early to prevent. And that I think is a bit of a gap for some states too. They just don't know what curriculum would be best.
And there's some great opportunities there again for the collaboration across the different sectors. So we are at the end of our time, and I just want to thank you so much for this great dialogue. The work you all are doing is just amazing, and it's such a difficult topic. It spans so many systems and so many age groups and so many kinds of nuanced disorders where we have all kinds of gaps and plenty of work to do. So thank you for the hard work, excellent work that you all are doing. Thank you. And to our audience, we have another seminar in 2 weeks. And so I look forward to seeing you there again. Thank you.